Next topic is Styphlococal Scalded Skin Syndrome. The other name for Styphlococal Scalded Skin Syndrome is Rita's disease as well. Styphlococal Scalded Skin Syndrome, it is common in children, and it is caused by an exotoxin of the Staphylococcus aureus. Styphlococal Scalded Skin Syndrome is an illness that is characterized by red blistering of the skin that just look like a burn or a scald. Hence, the name is Styphlococal Scalded Skin Syndrome. The other name for Staphylococcus Scalded Skin Syndrome is Ritter disease or Lyle disease as well. Staphylococcus Scalded Skin Syndrome, it is common in children younger than 5 years of age because usually lifelong antibodies, protective antibodies are developed against the staphylococcal and exotoxins. That's why it is not very common in older adults or in children older than 5 years of age. So the first thing that you need to remember about Staphylococcal Scalded Skin Syndrome is that it is common in children younger than 5 years of age. What are the other risk factors? Remember that this toxin, this exotoxin that result in Staphylococcal Scalded Skin Syndrome, it is cleared by the kidneys. And because these children or young infants, or they have an immature system of renal clearance, so that's why it is common in these children. And because this exotoxin, it is cleared by the renal system, so someone with a history of chronic kidney disease or end-stage renal disease, they can also develop this Staphylococcal Scalded Skin Syndrome. So immunocompromised individuals and individuals with renal failure, regardless of the age, may also be at risk of Staphylococcal Scalded Skin Syndrome. So 3 points you need to remember, or 3 risk factors. Children, because their renal system is immature, immunocompromised individuals, and individuals with renal failure, they are all at the risk of developing Staphylococcus Scalded Skin Syndrome. So Staphylococcus Scalded Skin Syndrome, it usually starts with fever, irritability, and widespread redness of the skin. Initially, there is fever and redness of the skin and irritability. Then after 24 to 48 hours, there is formation of fluid-filled blisters, and then these blisters rupture easily and leaving an area of a denuded skin. So can somebody tell me what are the other conditions that can lead to skin detachments? We discussed them in the previous lectures. A name of the condition that can lead to skin detachment.
Stevens-Johnson syndrome.
Stevens-Johnson syndrome, that's right, excellent. Stevens-Johnson syndrome and toxic epidermal necrolysis. So how you are going to differentiate between these conditions? On the basis of clinical features, we can say that Stevens-Johnson syndrome will be developed after an intake of a drug such as penicillin. And it will be common in older adults. While Staphylococcal Scalded Skin Syndrome, it is common in someone with a history of renal failure, and in immunocompromised individuals, and in younger children, younger than 5 years of age. So remember these risk factors and etiology of Scalded Skin Syndrome and Stevens-Johnson syndrome and toxic epidermal necrolysis to help you differentiate between these conditions. Nikolsky sign is positive in both Stevens-Johnson syndrome and Styphlococal Scalded skin syndrome. And there's a test on the basis of which we can differentiate between this uh, Stevens-Johnson syndrome and Staphylococcal Scalded skin syndrome, and that test is known as Zank smear. How Zank smear can help us in differentiating between these two conditions. The Zank smear is done usually in acute setting. It rapidly detects a herpes infection. So Zank smear can detect a herpes infection as well, and it can also be used to distinguish between Stevens-Johnson syndrome, toxic epidermal necrolysis, and Staphylococcus scalded skin syndrome. In Staphylococcus scalded skin syndrome, Zank smear will show acantholytic keratinocytes without inflammatory cells. So without inflammatory cells, the diagnosis will be Staphylococcus scalded skin syndrome. While with inflammatory cell and necrotic keratinocytes, then the diagnosis will be Stevens-Johnson syndrome or toxic epidermal necrolysis. So we can differentiate between them on the basis of history as well as on the basis of Zank smear. The management of both the condition is almost same. Both the condition require hospitalization, but because this Scalded skin syndrome, it is caused by Staphylococcus. So again, whenever you hear the name Staphylococcus, the antibiotic that should come into your mind should be fluoxetine. So fluoxetine is used in the management of Staphylococcal Scalded skin syndrome because of bacterial etiology. And if MRSA species are suspected, then vancomycin can also be used. While in the management of Stevens-Johnson syndrome, there was antibiotic is usually not required unless there are secondary bacterial infection. And the main management of Stevens-Johnson syndrome was corticosteroids, while in Scalded skin syndrome, corticosteroids are usually not used because corticosteroids, they slow down the healing of the infection. So that's why they are not given to the patient with Staphylococcus Scalded skin syndrome. Other supporting measures are common for both fluid and electrolyte monitoring, IV hydration, skin care, and painkillers. This is common to both of them. The only difference is that because SSS is caused by a bacteria, exotoxin of the Staphylococcus aureus, that's why fluoxetine is used as an additional management. Other management, that is supportive treatment, is same for both of them. One more difference between Staphylococcus scalded skin syndrome and Stevens-Johnson syndrome is that SSS is has a good prognosis. It is the disease generally the children will recover well, and healing is usually complete within 5 to 7 days of starting the treatment. While the prognosis of Stevens-Johnson syndrome is very poor, and it may take many days, many weeks until the lesions of Stevens-Johnson syndrome they disappear. On the other hand, Staphylococcus scalded skin syndrome has a very good prognosis, and the healing is usually complete within 5 to 7 days. So this was all about Staphylococcus scalded skin syndrome. I hope it's clear to everyone. Now our next topic is Bollous Pemphigoid. Bollous Pemphigoid, as its name indicates, these are the formation of bulla. Bollous Pemphigoid is an autoimmune condition in which there's formation of antibodies against hemidesmosomal proteins, BP180 and BP230. So due to this formation of these antibodies against these proteins, it results in the formation of bulla, which are usually tense and itchy. So tense itchy blisters in elderly patients. Remember these 3 points. Tense itchy blisters in elderly patient. Your diagnosis will be bullous pemphigoid. Flaccid blisters in young patients, in patients who are less than 40 years old, your diagnosis will be pemphigus. So bulla formation occur in both of them. In bullous pemphigoid, there is tense blister formation, and it is usually common in elderly patients. While in pemphigus, there is flaccid blister formation in younger people who are less than 40 years of age. Both of the conditions are autoimmune condition in which there is formation of autoantibodies against the proteins that are present in the skin. Due to formation of these antibodies, blister formation occur. So if the blister are tense, then and the patient is old, then your diagnosis will be bullous pemphigoid. Otherwise, if the patient is young and flaccid blister formation is occurring, then your diagnosis will be pemphigus. So pemphigoid and pemphigus. There's only a slight difference in the name. And in one condition, there is tense blister formation, and in one condition, there is flaccid blister formation. Skin biopsy will usually show IgG and C3 at the dermoepidermal junction. So if someone present to you with these features, you will refer to dermatologist for biopsy and confirmation of diagnosis, because both of the conditions are autoimmune conditions. So oral corticosteroids are the mainstay of treatment for both of them. Topical steroids, immunosuppressants, antibiotics can also be used if there's signs of infection. So management of both the condition is same. The difference between bulla and vesicle is that bulla are larger, usually more than 0.5 centimeter, and vesicles are smaller, less than 0.5 centimeter. So this was all about bullous skin diseases. That was bullous pemphigoid and pemphigus. Now, I hope it's clear to everyone.
So what is the cause of this bullous pemphigoid?
Formation of antibodies against the proteins that are present in the at the junction of the epidermis and dermis.
So it can happen only in immunocompromised patients, or it can happen with any person in which the autoantibodies can be formed against these proteins.
Yes, it can happen in any patient. Immunocompromised patient, because in immunocompromised patient there is a low immunity, so there are very less chances that this condition will occur in immunocompromised patient.
Right.
Autoimmunity is basically hypersensitive immune system. The immune system start to react against the body's own proteins. So it can occur in anyone with a genetic predisposition.
And they can be formed on any part of the body, like any part of the skin.
Yes, any part of the body, they can be formed in any part of the body.
Okay.
So tense blister in someone without any cause, then you will think about bullous pemphigoid or pemphigus. Blister formation without any cause, bullous pemphigoid, or the other condition in which there is bullous formation is Stevens-Johnson syndrome or toxic epidermal necrolysis. But in both of these conditions, there will be history of a drug intake such as penicillin. While in this case, there will be no such history. because the cause is usually unknown or autoimmune.
Okay, thank you.
So this was all about bullous skin conditions. Now our next topic is different type of skin cancers and some points about them.